Good evening, everyone. You're welcome to Focus on the Family Foundation. It's our privilege this evening to be hosting an interactive session with Dr. Kate Oga. She's a consultant microbiologist, and she's graciously accepted to come and talk to us about COVID-19 and vaccines. Many of us have been wondering what all this is, how the vaccines will affect us, whether the vaccines are necessary, and all of that. And today, by the grace of God, Dr. Kate will put our minds at ease, give us the scientific evidence. And thankfully, she's a mother, a sister as well, and she will tell us everything that we need to know and the right steps to take. We're all welcome. I will just briefly hand over to Mrs. Canos, the convener of Focus on the Family Foundation, to talk to us for a few minutes about what the foundation is and why we have taken this initiative to do this. And then we'll hand over to Dr. Kate to go ahead with her talk right away. Thank you. You're welcome.
Good evening, everyone. It's an honor and a privilege to have this first Zoom meeting from Focus on the Family Foundation. And we thank God that God has brought us this far, each and every one of us. Focus on the Family, actually, we started the foundation in 2015. And it came about by the ills in the society and the breakdown of law and order in society. And we just felt we needed to do something and contribute our own quota, knowing that the bedrock of the society is the family. The foundation in the family is what makes the society, is a reflection of what is out there in the society. So we started the foundation, and the foundation, I happen to be the conveyor. We have a team of people that partnership and works with us. You met just one of them now, Sakmichit Kumsua. She's been doing a very good job. What we do in the foundation is building and promoting a strong family culture and principles in families, couples, parenting, and the children. We know that there are 4 relationships that we've come to know. That's the relationship between husband and wife. We have the relationship between the parents and the children, and also the family, each and every one of us, and our responsibility to the society. So that's basically the framework that we have in Focus on the Family. And we have different outreaches and different aspects of things that we do in the foundation. We have a mentorship program for the young people, the young ones, boys and girls. We have a program to mentor them, and when you are talking about the family, you're talking about the society as well, to be good leaders. And also we have an outreach to the widows, orphans, and the almajiris, the needs, people in need, we take care of them. And also we have training programs and events for couples to bond together and to strengthen their relationship. So that's basically all that we have in a nutshell about the foundation. And today we're talking about coronavirus and the vaccine. Today happens to be the 27th of February, 2021. And a year ago, exactly a year ago today, we had the first record of the breakout of coronavirus in Nigeria. And I don't know how God worked out everything, and we are here today to talk about coronavirus and the vaccine. In Nigeria, you will know and reckon with me that a whole lot of people, I keep saying something, I don't think there's any family that has not had a victim and has not been plagued by the virus. Each and everybody you see. And here in Nigeria, we actually don't have enough information. You hear people say, oh, I had malaria. But at the end of the day, when they go for their testing, they end up getting to know that, oh, they had COVID-19. So it's an honor and a privilege to have each and every one of you here this evening. And also it's an honor and a privilege to have our resource person, a very good dear friend of mine. And she's passionate about her work, her job, her ethic is outstanding. And she's very committed to that which she does. I will hand over back to Mrs. Kumswa to give a brief introduction of who she is. Thank you very much.
Thank you, Mrs. Kanus. All right, everyone, you're very welcome. It's my honor and privilege to welcome Dr. Kate Oga to give us a few minutes of a lecture on the COVID-19 and the viruses. Dr. Oga is a mother in the house, a friend of ours, but she's also a consultant microbiologist at the University Hospitals of Morecambe Bay. And she's an NHS, which is under the NHS Trust. I've known her as a doctor for a very long time, but she's now based in the UK, and she's graciously accepted to come and talk with us here. So please listen carefully, take notes, feel free to ask questions. We'll have an open house after this. If you want to ask questions, you can send us the questions in the chat box, or you can just, raise up your hand and we'll unmute you to ask your questions after that. All right, thank you. Happy listening.
Hi, good afternoon, everybody, or good evening, wherever you are. I'm aware that people are joining from all over. So a good day to you all. I have been involved in the management of COVID patients in my hospital, which is based across 3 different sites and have been right from the beginning of the outbreak. So I am quite happy to have to share some of my knowledge with you and also to listen to your questions and see if we can address them. If there is anything that I cannot answer, then I'm happy to look for the answers and get back to you, because I'm aware that I'm not practicing in Nigeria, so I may not have all the answers for you because there are subtle differences in the localities or the different localities and how things are managed. But I thought I'll give you a brief run through COVID. It's not a long lecture. I just thought, at least give you an overview before you can begin to ask questions. So I hope my screen works and I can share with you. So a quick background. So what is coronavirus? Coronavirus, it's defined, it's an RNA virus. When we classify viruses, we classify them into 2 big groups. It's either an RNA virus or a DNA virus. And the coronavirus has been around with us for ages. It was first discovered in chickens in 1937. And it is commonly found in animals. In the human race, it was first discovered to cause infection in 1960. So again, it's been around for a long time. And most times when we encounter coronavirus before now, it's only associated with common cold. So when you're coughing and sneezing and, feeling non-specifically unwell, it may well be that you have coronavirus. So coronavirus is not necessarily always a very severe infection. This is what the coronavirus looks like. It looks like he's wearing a crown. If you look at the pictures here, the pictures here, you can see this is an electron microscope picture, and this is a drawing. So this is an actual photograph of the coronavirus. You can see some projections on the surface as if it is wearing a crown, and that is how it got its name, the corona. It's crown in Latin. So it's an RNA virus, and this crown or projections on the surface are known as the spike protein. I had to mention that because it gets mentioned a lot when you're talking about the vaccine, because the vaccine was created to attack, you know, the spike proteins on the surface of the coronavirus. So we will talk about it again later. Okay, so I said coronavirus normally causes common cold, but it has been associated with some severe infection in the past. The first one was called SARS infection, which happened in 2002 to 2003. It caused quite a lot of deaths then, but it was restricted to, you know, the not the Middle East, the Southeast Asia. It started in China and then quickly spread to Hong Kong and the surrounding region. And I think Canada was fairly affected at the time as well. But it quickly died down. So this was not a pandemic, but it was a serious enough infection for the world to be concerned at the time. Between 2002 to 2003, it only caused 774 deaths at the time. So that coronavirus, that specific one, is called the SARS-CoV virus. Then there is another virus, another coronavirus that's called You need to mute somebody up. Somebody's microphone is on.
Find the person you can mute.
Can you mute everybody who wants to call?
Let me mute my own friend.
Thank you. Okay, we'll go on. So the other serious coronavirus infection is called MERS virus, and it happens in the Middle East, Saudi Arabia, and the peninsula. And it is still going on till now and has been since, I think, about 2012. The death rate associated with that particular coronavirus is very, very high. Most of the patients who get infected end up on ICU. So there's a very, very high mortality rate of about 35%. And if you compare that to the one that we have at the moment, which is about 12%, then you know that it's pretty serious. But fortunately, it hasn't spread far beyond the Middle East. And you get it by drinking camel milk or coming in contact with camels. So that's how you get that. Then there is the interesting coronavirus that started, the one that we're in right now, which started at the time very far away in China. I used to say it's far away and we don't know how it's going to affect us, but it has gone on to affect, you know, the whole world. And there's practically no country on the face of the planet right now that's not been affected by
So sorry about that. Please continue.
Okay, so can you still see my my screen? Okay, so the COVID-19 started in China. We still don't know where it started. There has been speculations that it probably started from a seafood market in the Hubei province in China. Now, it actually started in the seafood market, but we don't know what animal was responsible. But there are speculation that it probably started from a bat. and then, you know, got into some other animals that were sold on the market, because this market sells all sorts of wild animals, and they feel that it might have come from a bat into the market through some other animal, but they're not absolutely sure. I think eventually we will find out, but as at yet, there is no conclusion as to what animal actually brought it into the human race. But this particular market sells all sorts of wild animals. So it probably started way back in 2019, December, but it wasn't until, you know, early part of 2020 where the outbreak started to spread all around the world, and still spreading as we speak. Okay, so who gets infected? Practically anyone can get infected, because this virus is a new virus. We haven't encountered it before, so nobody's got any immunity to it. That is why it's a very scary thing, because you don't know, you know, who's going to get it and how they are going to react to the infection. But practically everyone can get infected. But the infection is usually more severe in the older patients, more than 60 years old, and patients who have background of other, you know, illnesses such as diabetes or hypertension or lung problem. If you have breathing difficulties like asthma or COPD, patients who have cancer or heart problems, those are the people that are more severely affected than others. Now, in children, the infection rate is very, very low. Children can carry it, but the actual infection with COVID-19 is very, very low in children below the age of 18. So mostly older people are affected, or people who have underlying illnesses, and then rarely happens in children, even though they can carry it and they probably can spread it as well. But they do say that the infection rate and the carriage rate is pretty low in children. Okay, so how is this virus spread? We say it's spread by respiratory droplets, meaning if you sneeze or you cough, you talk loudly or sing in a big enclosed space, then, you know, you can spread this virus. It can also survive on a surface for hours to days. We don't know exactly whether this is responsible for transmission at the moment, but the main method of transmission is from person to person rather than from touching surfaces. However, we do say that keep the surfaces clean to avoid the risk of transmission, because we don't know how this plays a part in the transmission. The infection can take between 2 to 14 days to show, but most people who come in contact with COVID will have the symptoms by the 5th to 6th day. So within a week of coming across COVID, you will begin to show symptoms, but anything between 2 to 14 days. And the 14 days is important, which is why we say if you come in contact and you don't have any symptoms, you must remain isolated until 14 days have elapsed, because you can still show symptoms right up to 14 days. And some people don't show any symptoms at all. Those are the ones that we call asymptomatic carriers. So they're carrying the virus and they don't have any symptoms at all. We tend to have a lot of those now in the hospital, because we're screening everybody who comes into our hospitals for COVID, everybody. So if you come through the door, you will get a COVID screen, whether you have symptoms or not. And we are finding that there are more and more people who are carrying the virus, but don't have any symptoms. What are the symptoms that you show? Now, some of the symptoms are non-specific. So somebody has fever, has cough, just feeling tired, and body aches. Those are the kind of, symptoms that we see with COVID. And is pretty non-specific because you can have it with anything. So what people tend to do in places where you don't get tests readily is to attribute these symptoms to something else. Because you might say, oh, I have headache, I have fever, I am feeling really tired. I'm sure it's malaria, you know. So there is a lot of underdiagnosed COVID out there because especially in the developing countries, we don't have the facilities to test everybody who has symptoms, even in the bigger cities, let alone in the villages, you know. So a lot of it goes undiagnosed. But majority of people will have fever, majority of people will have cough. The cough is dry, the cough is constant. Some people will produce sputum. And for the first week, the symptoms are usually that. And some people then go on to recover after the first week. And by the 10th day, everything. So those are the people who have mild symptoms. But unfortunately, some people, who have severe symptoms will feel better initially. And then round about the 7th to 10th day, they have a relapse. And the explanation is that your body is producing antibodies to fight the infection. So all that time, the antibody is building up, okay? And then by that 10th day or 7th to 10th day, the antibody has reached a level where it's seriously beginning to attack the virus. But by attacking the virus, it's also attacking your tissues. So your antibodies, it's actually fighting your body. And that's why there is that initial response, and then suddenly there is a relapse. So you get better from the virus, but then the antibody starts to fight your own tissues. So that's what we tend to see, or rather what we tend to see in later infection. So non-specific symptoms, headache, feeling nauseous, feeling tired. Another symptom that people tend to commonly present with is the loss of taste and smell. Some people actually can't smell anything, and some have said that 9 months down the line, they still can't smell or they still can't taste anything, which is pretty scary, really, because you can't smell or taste. It's not a nice thing. Or some people say there is a change in taste. So you might taste, but it's not the same. Like if you like coffee, for instance, and then suddenly you try the coffee and it doesn't taste anything like coffee, then, you begin to wonder, do I have, COVID? Moving on. So does COVID do we have a treatment for COVID? The answer is there is no definite treatment. So there is no tablet that you can take and you will suddenly be cured of COVID, okay? But in the UK, when COVID started, they recruited a lot of hospitals to do a study across all the hospitals because we're actually using the same method to treat all our patients. So in the UK, they recruited 12,000 people into different treatment arms, as they call it. When we initially started, they said hydroxychloroquine is very useful and can treat patients, or that if you gave people azithromycin, people got better and things like that. But when you are actually, treating patients, unless you actually do a study, because one patient can respond to something doesn't necessarily mean that that's the treatment. So you have to do a proper study where you recruit a lot of people and test all the drugs that you think will treat this infection and find out which one actually works. And so in the UK, they did this study with 12,000 people. They tried hydroxychloroquine, they tried some anti-HIV medication, they tried an anti-Ebola medication, they tried some other anti-inflammatory treatment. And the only thing they found that reduces the death rate in patients who are ventilated is the use of steroids. Okay, so steroids sort of dampen your immune system. So you know that bit where your antibodies are flaring up and gearing up to fight your own tissues. What steroid does is to dampen that fight so that they don't attack your tissues. So they found that steroids was quite useful in patients and can actually reduce death rate in ventilated patients by up to 1/3 and in non-ventilated patients by up to 1/5. So moving on, I don't know if you guys have heard about this, but I do know that some of my medical colleagues in Nigeria have talked to me about the use of ivermectin. Ivermectin is a drug that they use to treat parasitic infection, river blindness, and some other kind of infections. I think they used it in Hong Kong and they saw a bit of response to it. And some people have what we call, I'll tell you what it is. It's not a study, but they have used it and they feel that it does help. So what needs to then happen is to actually do a randomized control trial and then try this drug and compare it to nothing and then see whether this drug actually does what it says, but they haven't done that yet. So even though some people are saying that ivermectin can be useful in protecting against COVID, we still need to do proper trials, because I might say it works for me. Another doctor might say, no, I tried it, it didn't work for me. And another one might say, oh yeah, it did work a bit, but unless you do a study and compare things, you cannot say categorically that ivermectin works. But at the moment, there are some suggestions that it might work in preventing COVID. Okay, so moving on. How do we prevent it? You know, I mentioned ivermectin, which is an ongoing thing, is being investigated. But some people in Nigeria, some doctors I know are using it already and recommending it for their patients to take every single day. Now, it has its own side effects. It's not a drug that you take willy-nilly, so you must have a good reason to take it. In countries where it is easy to enforce lockdowns have been used to control crowd meeting together, because we know that is when people come together that they spread the infection from one person to another. And if you're going to be around people, you stay 2 meters apart. So stay away from people that are not already in your household. And there is, at the beginning, there was a lot of debate on the use of face mask, but they have come to realize that somebody who's infected, if they wear the mask, then the cough doesn't travel as much as it would, you know, it stops where the mask is. So if I've got COVID and I'm wearing my mask, then even if I cough or sneeze, it's contained in there. It doesn't go as far as it should. So that's the logic behind the use of mask. If you wear a mask, you can prevent the spread of COVID. Cleaning of surfaces is another way of preventing COVID. And then finally, vaccination. And who would have thought that by the end of 2020, we would actually come up with vaccines that work against COVID. So it is a breakthrough that is very, very welcomed. And hopefully, as the world gets vaccinated, things will begin to open up again. Certainly in the UK, the rate of the vaccine uptake has been very, very high. Millions and millions of people. I think the last time they were counting, they had approached 20 million people. So people are taking the vaccine because it is found to be working. Okay, moving on. Now, what are the vaccines that are out there? There are so many vaccines now being approved for use against COVID. but they all do have different components to them. The ones that are used in the UK currently are the Pfizer vaccine and the Moderna vaccine, okay? And those two are what we called RNA vaccines. Now, there's been a lot of speculations about RNA vaccine and whether it affects the human DNA. Now, the way this vaccine is created is based on the way that the virus normally infects the human body. So how does a virus normally infect the human body? A virus is a very, very tiny, tiny molecule. It cannot exist on its own. It needs a living cell to survive. It's not like a bacteria. It's not like, you know, the human cell. If it doesn't have a living cell, the virus dies. So it needs to be able to infect a living cell. And once it enters the living cell, it does not even have all the equipment to multiply by itself. It relies on that living cell to help it multiply. So the virus gets into our body, and then it recruits our body to help it produce the proteins to help it survive. It goes into, it copies itself and attaches itself to our protein manufacturing factories. They're called ribosomes. And those ribosomes then help the virus to produce. And it actually, when it's coming out of our cell, it still steals from the covering of our cell to cover itself before it multiplies. So the virus is a very tricky cell. Now, what they have done, which is very clever, and it is not a new technology. This RNA technology is by no means new. It's been used now for a while to treat other illnesses such as cancer and all that. So what they have done is take the genetic material, the thing that codes for the virus to multiply. They take the genetic material and then they made copies of it. And then they presented the copy of those genetic material to our body the same way that the virus will normally do. And then our body produces the spike protein. And then once the spike protein is produced, it looks like it's the coronavirus. The body does not recognize it any different than it would an actual coronavirus. It produces antibodies, and then the antibodies are ready for the real coronavirus when the coronavirus attacks. I don't know if I'm making sense. So the DNA or the RNA is not derived from an actual virus. It is made in the lab, okay? And then it's presented to our body, and then our body makes, you know, what resembles the virus, and then the body produces antibodies and then waits for the actual virus to infect, and then it attacks the actual virus. So that's the technology of the RNA virus, or rather the RNA vaccine. Now people think, oh, because they hear RNA, they hear DNA, they think, oh, it's going to mess up with the human DNA, it's going to mess up with our DNA. It doesn't do that. It goes nowhere near your DNA. In fact, this molecule or RNA that's produced, as soon as the body starts to make the protein, the RNA gets destroyed within 2 days. So you don't even have a trace of that RNA in your body anymore. All that is left is the spike protein that the body recognizes as foreign, so that the body then starts to produce, you know, antibodies. So that's what happens when you get the Pfizer vaccine. Now, the AstraZeneca vaccine is slightly different. It's not based on RNA technology. It's an actual virus, but what they have done is they took the virus, the coronavirus, and they put it in another virus. They killed it first, obviously, and then they put it in another virus known as the adenovirus. This adenovirus normally causes common cold, but again, that is killed, so it can't do anything. So they use that as a cover for the coronavirus, and then they present it to the body, and then the body creates antibodies against the coronavirus. So the AstraZeneca vaccine does not use, you know, the RNA technology. Now, there are other vaccines out there. Johnson & Johnson's, there is a Chinese vaccine, There's a Russian vaccine. So there are several vaccines out there. And I am not absolutely sure which one is going to be available in Nigeria. I spoke to one of my friends yesterday who is in the Nigerian Vaccine Committee, and she said that they have been awarded 12 million vials of the AstraZeneca vaccine. And I think they also have the Johnson & Johnson's vaccine coming. I think the main difference between them, apart from price, of course, the AstraZeneca vaccine is the cheapest on the market. It's about £3 per vial compared to the Pfizer vaccine, which is almost £25 per vial. So that price difference is huge. So when you're considering a developing country, who is going to be able to afford, £25 as opposed to £3, I suppose the £3 will be more attractive. So the AstraZeneca vaccine is attractive in that way. The other reason that the AstraZeneca vaccine is attractive is the fact that the RNA technology is very complicated and it dies or destroys very easily. So you need to be able to store it in very, very stringent conditions. So you need a -70 degrees fridge to be able to store it. And if you don't store it properly, it can get destroyed and the vaccine won't work. So because of that, it makes it a bit difficult to sort of have the Pfizer vaccine, I suppose, in developing countries, because not many places will have the facilities to store the Pfizer vaccine, whereas the AstraZeneca vaccine can stay in a normal fridge for a while, so it doesn't need a special fridge. So all those make the AstraZeneca vaccine more available in developing countries. I think in terms of which one is more protective, I don't think there's one that's better than the other at the moment in terms of Moderna, Pfizer, and AstraZeneca. They all are equally protective. So if you get offered any of these, I would say take them. Now, there is a vaccine that the Chinese are producing that has been used in places like Brazil and Russia. And the report is that it's not necessarily as effective in preventing infection as the other vaccines are. So there is some prevention, but it's not as preventive. So the prevention rate is not as high with those vaccines. I'll move on. So how do we test for COVID? There are two main ways of testing for COVID. One of them, which is the easier, simpler way, is called a lateral flow test. So there is like a cotton bud there. It goes into the nose, high into the nose. And the idea is to take as much material as possible. Then you put that into this tiny tube here, and then you add some of the liquid from here. And once the liquid has been added and mixed together with whatever the swab has, you put it right into that hole. And it's like a pregnancy test. If you are a woman and you've done one of these pregnancy tests before, it looks exactly like this. So if you see one line, it means that the test is working, but that result is negative. If you see two lines, it means that that result is positive. So 2 lines is positive, 1 line is a negative. Now, what are the advantages of this lateral flow device? It is very fast. It takes between 15 to 30 minutes for you to get your result. It doesn't need any special equipment. So all you have is that tiny little kit with the buffer and the swab. It costs between 7 to 23 pounds. Now convert that to Naira, I'm not too sure. And it can be done by anyone, including the patient themselves. So you can do it in your own house and see the result for yourself. So what they have done in the UK is to provide a lot of this test for doctors and nurses and anybody who works in the healthcare system, so that you test yourself every 2 days. They say that the result is more likely to be positive if you are 2 days before your symptoms actually appear. So those people who are incubating the virus and are almost going to come down with symptoms, that is the best time for doing or rather, that is the time where the test is more likely to be positive. Now, there are lots of false negatives, because sometimes when people do the test on themselves, they don't push the swab high enough. They don't take a good enough sample, because, to be honest, who wants to push a swab right to the back of their nose as if it's going to your brain? It's a horrible experience. So most people who are doing it on themselves won't do it properly. So you will think, oh, it's negative. Meanwhile, it's not actually negative. It's just because you haven't done it properly. So you do get a lot of false negatives with that. And it's pretty scary, because some people might think, oh, I am negative, I don't have any virus, now I can go party with my friends because we are all negative, we've tested ourselves and we're negative. It is not true. You still need to observe your social distancing, your 2 meters apart and things, because it is not a true representation, because it can be falsely negative. Now, the next method for diagnosing COVID is what we call PCR. PCR is a method for diagnosing the molecular component of the virus. So PCR has been around forever, okay? So it's not new. We use PCR method to diagnose viruses. We use them to diagnose bacteria. They use them to check people's lineage. For instance, if you want to know what your DNA is made of, you can use a PCR to do that. So the technology has been around. So what does a PCR actually do? So this is the machine. It obviously requires a lot of preparation, a lot of reagents, a lot of tubes. And what tends to happen is that if there is a DNA that you're looking for, okay, whatever you have in your reagents should be able to bind to that DNA, so that then the DNA gets multiplied lots and lots of times. So the PCR is able to pick even the tiniest amount of material that's out there. So if you are COVID positive, even if you're only secreting a very, very limited amount of virus, the PCR will be able to pick it up, because it acts like almost like a photocopying machine. It's photocopying lots and lots of the genetic material or the RNA that's contained inside the virus. So that's the mechanism of action of PCR. The PCR, even though it's very, very sensitive and can pick up a lot of very minute amount of virus out there, and is very, very accurate, it is an expensive test. It costs about £200 for you to run one PCR. Having said that, there are some machines that can do like 40,000 tests in 6 hours, as opposed to another machine that can do, 10 tests in 1 hour, or one machine can do one, they have different types of machines. So that's not the only PCR machine. There are some that can spew out lots and lots of results within the day, and some can spew out only one result in 1 hour. So depending on what PCR machine you're using, the cost can vary quite dramatically. The disadvantage of a PCR is that it cannot tell you whether the material you're picking up is dead or alive. So you could be like, actually you could have come over your infection and be recovering, but the virus is still hanging around and it will still pick the dead virus. So sometimes we have patients who are 3 months down the line, they've recovered from COVID, but they are still positive by PCR. In that scenario, you have to use your own clinical judgment to say, this patient was positive 3 months ago. There is no way that that virus is still hanging around. So we are picking dead virus here. So you use your clinical judgment to overrule the result. because it can be quite confusing for nurses on the ward when they send the sample and it comes back and it's positive, and they're like, oh, where should we put this patient? Is it positive? Is it negative? And in that case, you have to say that the patient is probably negative and you're picking dead viral material. I think I'll stop there. So that's a brief overview, and I will welcome questions. Thank you.
Thank you so much, Dr. Kate. That was enlightening. You know, I was just listening and I thought I was following the coronavirus thing, but no. I've learned so much today, and actually I've learned so much that I don't think I have any questions. But thank you so much. I will just ask now. So, being a Nigerian, one of my friends said, we'll tell the story of how coronavirus became malaria in Nigeria. So we're not testing, there's a lot of denial, and then now we don't know what drugs to take. Like the last point you made about dead viruses, I've known people who have gone for tests, they feel okay. They did the PCR test, I believe. There's that rapid test, there's the rapid test that we do in Lagos that is like a malaria test, and it just keeps on showing antibodies. So in that case, what do we do? And then is there really is there any drug that you can take to flush out whatever is there, the dead viruses around? So that's the first question. And then secondly, what do we do in Nigeria now? People are hardly wearing face masks. Everybody just going around as usual, spitting malaria. What would you advise? Please, if you have any other questions, anybody that has a question, just raise your hand. I see a hand somewhere.
Okay. I'll try answer your first question. You said, is there anything you can take to flush the virus out? And the answer is no. The virus will linger, and it would eventually disappear from the system. The thing is, most people will not go for testing unless they are symptomatic. So if you're symptomatic and you go for a test and it is positive, believe the test. Don't say, oh, it's a false positive, or it's malaria I have, it's not COVID. I would believe the test if you're symptomatic, because the reason you went for the test in the first place is to get tested to see whether you have COVID. Now, you know, the quick test that you talked about, I don't know whether it's a lateral flow test, the 15-30 minutes test. If it is positive, you should believe it, because it is more likely to be negative than it is to be positive. So if it is positive, then I would believe it. It doesn't pick the dead virus, okay? So that's only a PCR that picks the dead virus. In terms of PCR, sometimes in our hospital, because we are using it for everybody, even patients who are not symptomatic, we are finding a lot of people coming back and telling us, oh, I had COVID back in December, you know, and it is still positive. What does that mean? And the answer there is, if you're not symptomatic and you have had COVID and it's more than 14 days ago since you last had COVID, then that result is more likely to be dead PCR that you're picking rather than a live virus. Wearing of masks, like I said, it's the reasonable thing to do. It protects people around you. So, like I said, a lot of people have the virus that are not symptomatic. So you're not going to find somebody, oh, this person doesn't have fever now. See, they're dancing around. They're not unwell now. So we must all be okay. We don't have the virus. No, because you can still carry the virus asymptomatically. So if you're in a big crowd, I would wear a mask. You wear the mask to protect yourself, but wear the mask to protect others as well. And if somebody is not wearing a mask, stay far away from them, because you can get infected. If people are not wearing masks, stay 2 meters away and stop shaking hands and hugging and things like that. I think for us, hugging and shaking is off the books for now until further notice. we're mostly at home anyway, so kids are home and things. But in the Nigerian situation, Nigerians like to take risks. They take risks every day. I think we're just used to it. And that's the way that life rolls in Nigeria. So you can't convince somebody to wear it. They're like, that's in no day here, Joe, you know. It's in other places, but we don't have it here. But that's not true, because honestly, the number of deaths I have seen recently on social media in Nigeria is just so alarming. There is no day you go on Facebook, you don't see 2-3 obituaries. Somebody is saying this person rest in peace. And I'm thinking, this is really sad, because it wasn't like that, you know, a while ago. It wasn't like that a year ago. So you know that these people are not getting tested. So why suddenly all these people passing away after brief illnesses? Nobody can explain that. And there are no figures, no numbers, no screening. So it makes the whole situation very, very difficult to convince somebody to accept that actually what's happening is COVID without actually checking. So I suppose it's a helpless situation, because people like to bury their heads in the sand when they feel there is no solution. And that's what's happening in Nigeria. But I think everybody should do their bit to stay safe, to protect you, to protect your family, to protect your loved ones. Do your bit. I'm ready.
Thank you so much, Dr. Kate. Thank you. I can't see any hands, so I'll just hand over to Madam. She has some questions, and then please feel free to send a question in the chat box if you don't want to talk. Thank you.
Thank you very much, Dr. Kate. It's really been enlightening hearing from you. I keep saying, oh, most of the things you're telling us, we've heard it, but we don't really do anything about it. And I'm happy we're having this discussion. But one or two things that I want to find out from you. One is, I know of some people which you've explained, but I really, really want you to go a bit deeper into it. They've done the test, they had COVID. 14 days pass, 23 days, blah, blah, blah. They go back, they do the test again. They're still positive. They stay back home, they are fine, they're okay. They go for the test again, because sometimes it depends on the organization you're working with. They want you to present a COVID test results that you are okay and fine before you come back to work. They do the test again and they're still positive. So I know you've explained it, but I want you to explain it a little bit deeper for us to be able to understand. And then another one I have is how effective is zinc. A whole lot of people keep buying zinc. You know, Nigeria, we are we're one-way traffic. When you hear this is working, even if it's not working for you, you just go and do it because you heard it worked for so and so. So how effective is zinc and vitamin C? Because a whole lot of people use that and take that. And also, how long does it take the COVID virus? How long does it take for you to be able to go back, have your screen done, and then you come back with a result that says you are negative? I think that's, well, I'll just ask that, and then I still have some other questions if people are not asking. Thank you.
Now, if you have had COVID and you go back 14 days down the line and your result is still positive, okay? In our scenario, hospital scenario, we would say if the patient is more than 2 weeks after the initial positive and you're still getting a positive 2-3 weeks down the line, then, and the patient is not symptomatic, then you regard that patient as a negative. Then it means that you're picking that virus, like I said earlier. The rule is slightly different if the patient is still symptomatic, like if they're still coughing, or they're still having temperature and things like that. And if they have any depressed immune system, they can shed the virus for longer, okay? So some people can shed the virus for longer. So the rule only applies to people who don't have any depressed immune system and who are not symptomatic with fever or cough or anything that may suggest that they still have the COVID. Then you have to regard that result as a false positive. Now, you can't tell who is going to excrete the virus for 3 months and who is going to excrete the virus for 2 weeks or 3 weeks. I don't think we can tell categorically. So if your workplace is such that they say you have to present a certificate of clearance before you come back to work, and there is nobody advising them that this is probably dead virus because this woman has had this thing 3 months ago, that is if the initial test was properly done and if it was a true positive, then we have to assume that,
Sorry, I need to also comment because I've seen a whole lot of situations. I've seen some people, even for students who were planning to travel abroad to start their school, and they did the test. It came out negative, positive. They isolated, did everything, and then 2-3 weeks down the line, they still did the test again. They are still, and then you can't travel because the result says you are positive anyway. So do you have any information as into what the whole law is against, in that aspect?
I mean, I can't speak for individual organizations, and they may not understand the way that the virus actually works. And they might be taking the results as black and white, okay? Whereas we know as microbiologists that it is not necessarily black and white, because we are now seeing people who 3 months down the line without symptoms are still positive. So in that case, it is difficult for me to say, because if the organization is saying you need a negative result, then I suppose you just have to wait it out and pray that, your result eventually becomes negative. Now, how long it will take, I have no idea, but I have seen people that are still positive 3 weeks, 6 weeks, and sometimes 3 months down the line. You did ask something, and I'm not sure. If you have had COVID before, you will have antibodies in your system. So perhaps those people need to do an antibody test. And then if it is positive, they can present and say, listen, I had it before. Here is my antibody. It says it is positive. So whatever you're seeing right now is probably dead virus because I now have antibodies. It is thought that the antibodies, though, after an infection will wear off after 6 months. So if you had COVID before and you have antibodies, you have to get vaccinated if you've had COVID before, but you wait for at least 90 days before you get your vaccine. Did you ask me another question?
Yes. How effective is zinc and vitamin C?
Right. Now, there are so many people pushing different types of vitamins and things that you can take. When it comes to common cold, we do know that zinc and vitamin C do help. But as far as COVID is concerned, these things have not been proven to help. So I can't sit here and lie to you. The only thing that has been found to help, particularly in Blacks who live in a place where the sun does not shine that regularly, is vitamin D. And the UK government is actually rolling out a program where they are supplying all the Black people with dark skin and things with vitamin D so that they can take, because they have found studies have shown that it is protective against COVID. But zinc and vitamin C and things like that have not been found to be protective. I can't say, take vitamin D if you live in Nigeria, because you guys get a ton of sunshine. So long as you're out in the sun, you should get enough vitamin D naturally, and you don't need to take them. But we who stay here in this cold weather, no sun, we're not even getting out of our houses at the moment. We have to shack vitamin D every single day. Yeah, so vitamin D, yes, but zinc and vitamin C, no proof that it works. It might help your sore throat though, it might help.
Yeah, thank you, Dr. Kate. We have one other question here. So person wants to find out what is the shelf life of the vaccine, and how long does it last in your body? So like we have vaccines that you take once in 10 years and things like that. What's this vaccine? What does it do?
Now, this vaccine is being rolled out, and no one knows how long it's gonna last. And we already know that you need 2 doses for it to work properly. Only one of the vaccines so far offers only 1 dose. I think it's Johnson & Johnson's, but all the other ones you have to give at least 12 weeks apart, or at most 12 weeks apart, for it to be effective. What they are thinking is that it may well be that the coronavirus has come to stay, just like the flu virus, and that every year we may need a booster of the vaccine. But I think it's too early to say what is going to happen in the future. If perhaps everybody gets vaccinated and they are immune, and the herd immunity, like everybody is immune, and the virus does not find a new host to infect, it may well die out and not be around for as long, but that is too early to say. So we have to just wait and see. It may well be that we need the vaccine once every year.
Thank you so much, Dr. Kate. I can't see any questions. Please raise your hand or just send a question in the chat box. But let me just ask again about the fears that a lot of Nigerians have. Many different fears. You try to address some, but so the idea that there's some material in the vaccine that is not good for us, like pig fat, aborted babies, and things like that. Aborted baby fetus and all sorts of things that has just gone into the vaccine. Those are fears. Those are people. That's what people are saying. Like all these things are in the vaccine. They don't tell you because you don't read. They hide it under scientific names. You don't know. And these are some of our issues.
Okay. I understand where that is coming from. You know what?
Sorry, before you answer that question, I just want to chip it in, because when we brought up this topic and I was talking to one or two of my friends, they're like, you see all these doctors, they are all the same, or they will lie to you, they won't tell you the truth. So and I assured a whole lot of them, I'm like, look, I know her and she's going to tell you the way it is. She's been here, she grew up here, she's a Nigerian, and she's in the system. If it's something that is going to be harmful or not true or good for us, I'm very, very sure she's going to say it. So your honest opinion, your own honest opinion about the vaccine. And because some people are even asking, okay, see, in the list they are saying the amount of for the pricing of the vaccine. Why are they giving us Nigerians the cheapest one? That means there's something wrong. Why is it that they are taking, and these ones are specifically written, this is not for the developed world, it's for developing nations. So those are the things that people are battling and dealing with. And I just hope people will ask questions, this is the opportunity to ask the questions. Thank you.
Yeah, please bring the questions in. Mrs. Kumso, I'll answer your question first. You said, is there any pig or fetal material in the vaccine? I can understand where that question is coming from, because viruses are not able to grow by themselves. They need a living cell. So normally when a virus is cultured, you need a cell line. Sometimes they use egg, sometimes they use monkey cells and things like that. So yes, I understand where the question is coming from, but you know, this particular vaccine does not have any human material, and it doesn't have any animal material either. The Pfizer vaccine, like I said, is like RNA that's created in a test tube, using just molecular genetics, you know, and they also applied some fat around it. And this fat is called ethylene glycol, and it is present in lots and lots of cosmetics and other vaccines. Is used to protect the genetic material to be able to deliver it to the right place for it to act. So there is no pork and there is no fetal material in any of the vaccines. The AstraZeneca vaccine has, like I said, an adenovirus that's derived from a chimpanzee. So this adenovirus is not a human adenovirus, but it's a chimpanzee adenovirus. That is what they used as a transport medium in the AstraZeneca vaccine. So none of them contains pork or human material. Now, coming to your question, Makeni, about fears that people have. I can't quite remember the question. I really should be writing them down. You said something about changing your DNA. Was that what you were asking? Whether it affects your DNA and things like that. I did say already, it does not affect your DNA. And the reason why the vaccine is subsidized for Africa is because, listen, these vaccines are expensive, okay? And if you want to wait for countries who can afford it to all get it before the developing countries can get it, it's a bit unfair. It's like saying only the rich people deserve to survive, okay? So there are some vaccine, there are some associations that are actually fighting for poor countries to have a percentage of the vaccine without having to pay for it, okay? So they're saying for every maybe 50 million vaccines that you make, you must make 10 million available for countries that cannot afford it. It's only fair, it's only humane. And you can understand that because I'm just even thinking, if you get this vaccine out to Nigeria today, unless you have enough to vaccinate everybody, only the rich are going to get vaccinated. Have you guys thought about that? Only the people who can actually afford it will get vaccinated. So already we have that problem. And did you know that up till now, unless you've traveled out to go and get your vaccine, which I heard Atiku has. He went to Dubai to go and get vaccinated. So there will be more and more people like that when countries open. If they are able to lay their hands on the vaccine, they will go and buy it and vaccinate themselves, okay? Which means only the rich will survive. So that is not humane at all. So